I think if you write anything down from today's program, you may want to write down what I consider the 4 key questions to ask. 4 questions has sort of a biblical connotation too for those of you who are familiar with the Passover holiday. At the Passover Seder, one asks 4 key questions. And I think for those who are on anticoagulation and for the families and friends of those who are on anticoagulation, here are the 4 key questions. And this is really my principal message to patients, and I think it really transitions very well from what Henry and the discussants of Henry's talk had to say. First, step back and ask, why am I being anticoagulated? Second, what are the risks versus the benefits of anticoagulation? And you should be asking that for all medications you're taking. And 3, the question to ask your clinician, how did you select the particular anticoagulant that you are prescribing for me? And parenthetically, shouldn't we be discussing that? Are you putting me or proposing to put me on warfarin or one of the novel oral anticoagulants? And if you're advising a novel oral anticoagulant, which agent? We have 2 that are available now, dabigatran and rivaroxaban, and probably by the end of the year we'll have a 3rd one, apixaban, and probably a year after that, edoxaban. So the field is rapidly evolving. And the 4th question, one that Henry addressed directly in his talk, how long should I be anticoagulated? So we've discussed the common indications for anticoagulation: preventing stroke after atrial fibrillation, treating and preventing DVT and pulmonary embolism, and mechanical heart valves. Let's discuss the risks of warfarin. Everyone knows the bleeding is the #1 risk. That's true with any anticoagulant. I do want to mention some less well-known adverse effects of warfarin. And the way you get to know these is by talking with patients. I have the benefit of having 3,300 patients on anticoagulation right now in the anticoagulation management service. So we have a lot of exposure to the various problems and to some of the less well-known adverse effects of warfarin. I think of those, one of them is hair loss. A second, quite of great concern to me as a cardiologist, is calcification of the coronary arteries. Now, I know everyone takes supplemental calcium and vitamin D. It seems to be the rage. One place you don't want calcified are your coronary arteries. A third, in the world of endocrinology, it's well known that there is a likely association between warfarin and osteoporosis. And then there are other complaints about being on warfarin that I'd call quote-unquote soft. In other words, I hear them frequently in my office practice and from among the 3,300 patients under our auspices at Brigham and Women's, but there hasn't been much research in them. One of them is sort of a generalized feeling of fatigue, and the other is what is always described to me as a cold feeling. I've heard it so much, I'm just wondering that there has to be something to this. but there's never been any large scientific study. But I'm always suspicious, particularly when I switch these patients to a novel oral anticoagulant and these long-term symptoms go away. I want to point out that in adults over 65 years old, speaking about ERs, there are about 100,000 emergency hospitalizations each year in the United States for adverse effects of medication. That is such big adverse effects that the patient needs to be hospitalized upon presentation to the emergency department. And of all the dangerous medicines that we prescribe as physicians, number one on the list for emergency hospitalization due to adverse effect, accounting for 46% of the emergency department visits and accounting for 33% of emergency hospitalizations, is warfarin. Warfarin, more dangerous than insulin, which can cause tremendous hypoglycemia. Warfarin is number one. Now, let's flip this, because the issues, it's always benefit versus risk. What are the benefits? Warfarin has stood the test of time since 1954. We have agents we can administer to reverse its bleeding effect. Its levels are readily measurable, it's inexpensive, and we have the benefit, really a treat, of being able to call up our primary clinician in our anticoagulation management service at Brigham and Women's. That would be a doctor of pharmacy, and other anticoagulation services, it might be a nurse. There are 4 novel oral anticoagulants for you to keep your eyes on when you're reading the news. 2 of them are FDA approved, dabigatran and rivaroxaban. Apixaban is going to undergo FDA hearings in June next month, and edoxaban will probably be presented to the FDA about a year and a half from now. Now, what about the novel oral anticoagulants? Of course, they have risks too. We don't have a decades-long track record. We don't have yet specific antidotes, nor can we measure drug levels. And we have to be careful about deterioration in renal function, because most of the currently available novel agents are metabolized by the kidney. But these novel agents have tremendous benefits also. They're either equivalent or superior to warfarin for preventing stroke. All of the agents across the board cut down the most dangerous type of bleeding, which is bleeding into the brain, by about 50%. We don't understand why they're safer, but they're safer for the most dangerous of all the bleeding complications compared with warfarin. And they have an immediate onset of action and a short half-life. So if someone needs a colonoscopy, you simply omit 1 or 2 doses of the novel anticoagulant, and that's it. There's no bridging with low molecular weight heparin. And they're prescribed in a fixed dose. You never, ever need to adjust the dose of the novel oral anticoagulant, and you never need any blood tests. There are no more INRs that are required. So you never need to go have your blood drawn to do any measurements, because you never use measurements to change the dose, because you never change the dose. Furthermore, there are minimal drug-drug or drug-food interactions. What does this mean in practice? For those of you who are yearning to eat as much spinach, broccoli, Brussels sprouts, go ahead. Be my guest. you are liberated to do so. You know, we always say that if you're on warfarin, you can still eat green vegetables, but you have to parcel out the same amount 7 days a week and keep it steady. Well, let's say you happen to be a binge green vegetable person, and let's say you only like to eat spinach and Brussels sprouts on the weekends. You can do that on the novel oral anticoagulants. And, you know, as a physician, now I carry around literally a website to list the hundreds of warfarin drug interactions, because you can't memorize them anymore. There are too many. And they can make the INR go up or make the INR go down. Now there are only about half a dozen important novel oral anticoagulant drug interactions and virtually no drug-food interactions. So these are some of the benefits of the novel oral anticoagulants. So they range from these convenience issues and quality of life issues like being liberated to eat healthy vegetables whenever you want, to the more serious issues of having more or less a 50% reduction in major bleeding or life-threatening bleeding compared with warfarin. And I think this slide simply summarizes the differences. So, if I'm taking warfarin, should I switch to one of the new agents? The two currently available agents being dabigatran and rivaroxaban. That's an easy yes if bleeding or clotting problems have occurred on warfarin, but it's more challenging if all is going well, because on one hand, the right side of our brain is saying, don't rock the boat, but the left side of our brain is sort of looking at the trials that are done against warfarin, where these novel agents have really shown definite advantages to warfarin, which is why the FDA has approved them. Advantages in terms of less major bleeding and in some cases fewer strokes. Okay, we issue professional guidelines. And these professional guidelines are not written collaboratively. They put a bunch of experts in a room, and basically we're there for 3 days, and they don't let us out till we come to consensus. So I've had the privilege of being on several guideline writing groups, including the American College of Chest Physicians, or ACCP. We issued in February of this year our 9th edition of guidelines. I've also had the opportunity to be involved with the 8th and the 7th and the 6th set of guidelines. So I've sort of watched the field evolve and watched the guideline process evolve. So let me share with you what these guidelines say. These guidelines, though published in February, basically went to press about a year before that, before rivaroxaban or apixaban or edoxaban were available. And it says for patients with atrial fibrillation, including those with paroxysmal atrial fibrillation, we suggest dabigatran 150 milligrams twice daily rather than adjusted dose vitamin K antagonists, which means warfarin therapy. Now, what we've had to do in the past when we're starting someone on anticoagulation is give what we call parenteral or injectable agent that works within an hour or two, such as unfractionated heparin, low molecular weight heparin. Henry mentioned that he had received Lovenox. The generic name for Lovenox is enoxaparin. Fondaparinux or Rixtra, and there are these direct thrombin inhibitors. Of course, the reason we had to use a parenteral agent is because warfarin takes 5 to 10 days to be fully active, as Dr. Connors explained in the opening lecture of our patient seminar. Of course, the novel agents work within 1 or 2 hours. So there's the potential with the novel agents never to need a parenteral agent. I do want to mention one area where parenteral therapy is still the standard of care, and that is for those of you who have active cancer plus a DVT, or active cancer plus pulmonary embolism, a low molecular weight heparin should be given without any oral agent because it reduces the risk of a recurrent event. I think what we're going to see in the future is what I've labeled the single drug approach. Over time, we're going to see that these parenteral agents, for most patients with new onset of clots who require anticoagulation, that a single oral drug will be administered because the oral drug works in 1 to 2 hours after swallowing the capsule or pill. And it's really it's a game changer. It's going to revolutionize the way we care for you. Now, for DVT and pulmonary embolism, what do the guidelines say? The guideline committee must have been aware of the results that were published in April of this year for treating new onset DVT or pulmonary embolism with the oral agent rivaroxaban, especially because these recommendations were really written a year before they were published, and then they went through a vetting process. And the guidelines recommend for acute DVT or pulmonary embolism either initial parenteral anticoagulation or anticoagulation only with the oral medication rivaroxaban. Okay, and then the last question is, how long should I be anticoagulated? If it's an issue of stroke prevention for atrial fibrillation, usually lifelong. If it's mechanical heart valve, it is definitely lifelong. And for DVT and pulmonary embolism, there is a tendency toward extended anticoagulation because we realize that if you had a blood clot that occurred out of the blue and you discontinue anticoagulation, I would say Henry's story we classify as a blood clot that occurred out of the blue. Yes, he was on crisscrossing the country, and yes, he was sitting in these board meetings negotiating with people for 4 days nonstop, but that is considered out of the blue as compared with surgery or trauma, which would be considered a provoked event. And if you stop anticoagulation and follow patients for 10 years, as was done in this study in Padua, Italy, where people enjoy growing up, living their lives, so you can follow them for a long time, the recurrence rate's about 50% off anticoagulation over the ensuing 10 years if you started off with an unprovoked pulmonary embolism or DVT. And if you had a provoked event, such as surgery, trauma, a birth control pill, pregnancy, hormone replacement therapy, then the recurrence rate's still pretty high, 20% over the ensuing 10 years off anticoagulation. Risks for recurrence, number one risk is an unprovoked event, but also strong family history or a previous history of DVT or pulmonary embolism, having the blood disorder antiphospholipid antibody syndrome or cancer are also risk factors for a second DVT or pulmonary embolism. Cancer, probably because cancer secretes substances that make the blood clot, predisposes to a recurrence. I'm sorry to say for us guys, the male gender, for reasons we don't understand, predisposes to recurrence. And then presenting with symptoms of pulmonary embolism rather than symptoms of DVT also predisposes to recurrence. Now, it's not as simple as doing a venous ultrasound of the leg or doing a repeat chest CT scan to figure out how long to keep someone anticoagulated. Because if you take all comers who've had DVT and check them out 36 months after the event, even if they're on anticoagulants, about 1/4 will still have persistent clot that can be visualized. And for pulmonary embolism, if you do a repeat chest CT scan, which has a lot of radiation associated with it, 1 year after the event, about half the patients are going to have clot that's still visible. The visible clot is not a very good predictor of whether another event will occur. But it's really the circumstances under which the initial clot occurred, provoked versus unprovoked. That's a very powerful predictor about whether there'll be another event. So the current guidelines state that if provoked by surgery or some sort of transient risk factor, anticoagulation for 3 months should suffice. But if unprovoked, we suggest extended anticoagulant therapy for longer than 3 months. Many patients will fall in the gray zone. You were not sure whether it's a provoked or an unprovoked event. For these patients, we have to consider past history, family history, gender, whether there is recanalization of the blood clot on the venous ultrasound exam, hypercoagulability studies, and, of course, since we're in the world now, the new model of collaborative care, patient preference. I think the final point of what a clinician wants to share with patients is a very interesting problem of medication adherence. Just because we write you a prescription or fax a prescription to your pharmacy, that doesn't mean you're going to automatically take it. And now I have to say that in my own practice of cardiology, those patients of mine, who are healthy, particularly if they've had some sort of cardiac condition, at a baseline, they're on 5 different drugs, 2 antiplatelet agents, a statin, an ACE inhibitor, and usually 1 additional drug, a beta blocker, to reduce myocardial oxygen demand. That's sort of the baseline. So, and then if you're sick, we're adding more medications on top of that. So it's a lot for the patient's point of view to keep track of all these different medications. And medication adherence and failure to comply with the prescribed medications is quite rampant. It includes failing to fill or refill a prescription, omitting doses or overdosing, prematurely discontinuing a med, borrowing someone else's medication, taking a med with prohibitive foods like antacids might prevent the medication from getting absorbed, or taking outdated medication. In the elderly, this is a special big problem. And this is part of my message, because if we collaborate, when we ask you, are you taking your meds, please tell us whether you're really taking them. For these new anticoagulants, we can't measure whether you're taking them. So it's just your word of honor, and it can really make a difference. Because remember, for the new anticoagulants, we don't have an INR. Whereas if you say you're taking your warfarin and your INR is consistently 1.0, we have to have a longer conversation. Here are the statistics gathered by our government on medication adherence in the elderly. 1 out of 3 elderly never comply with their meds or discontinue them prematurely. More than half make errors while taking their meds. 1 out of 5 of elderly never initially fill a prescription that we write. And it is a false concept that the elderly are having their meds put out for them by someone else. 95% of the elderly, and this certainly includes my 86-year-old mom, who lives by herself in a big house, are responsible for their own medications. As one of the Surgeon Generals, C. Everett Koop, said, drugs don't work in patients who don't take them. Now, one of the features of today's patient seminar that I'm so proud of Julie for incorporating into the agenda is you're going to see in the breakout sessions the patient-clinician collaboration. It goes far beyond medication. Prescribing meds is just one little thing of what we're doing. We're interested in your cardiovascular health, your cardiovascular wellness. Of course, that means we would like you to take the prescribed medications as directed. And if you're not doing that, to please share when we ask you in the office, what are you actually doing, just let us know so we can adjust accordingly or discuss with you accordingly. Remember, the latest research in exercise is that you can prolong life with daily exercise for at least 30 minutes a day, 6 to 7 days a week. Remember, heart-healthy nutrition is so important. We often have patients in our practices who are on paper anyways, on perfect medication regimen. But where's the exercise? Where's the heart-healthy nutrition and the cardiovascular wellness? We need to, with the wellness and the exercise and the nutrition, and often with the help of statin medications, achieve an excellent lipid profile, which will also prolong life, reduce stroke, reduce heart attack, reduce congestive heart failure. And we have to do more and more to help prevent and treat diabetes. Here are 3 reliable sources for medical information. Some of you, when you initially meet me, come in with very long printouts of information from the web that is not reliable. And, that's scary and misleading. I think to really sell magazines and newspapers, it's so a scary story, one that is not balanced about risks versus benefits of a med, one that focuses on a risk or blows it out of proportion can do a lot of harm. And these 3 websites, Medscape, theheart.org, natfonline.org, they'll give you the straight scoop. In conclusion, picking up on Henry's theme, in continuing our theme of collaborative model of medical care, you need to ask those 4 important questions. Understand why you're taking anticoagulants. Learn as much as possible both the risks and the benefits of the anticoagulant you've been assigned. Understand the rationale for the duration of therapy that is being recommended by your clinician. Adhere to the anticoagulant you've been prescribed. And finally, and perhaps most importantly, above and beyond the medication you've been prescribed, embrace, buy into the concept of cardiovascular wellness. Thank you very much.